Okay. Well, good morning, Dr Aiyappan.
Good
Thank
morning,
you for
Tracy.
coming to see us today and sharing your information. So we're going to be talking about breathing, respiratory care and ventilation for patients with motor neurone disease. So firstly, does everybody with motor neurone disease experience respiratory distress or dysfunction?
Unfortunately, they do. So, as you probably know, motor neuron disease affects all the muscles generally. So, as either in the beginning, when if they get respiratory muscle dysfunction or problems, or later as the disease progresses, when they develop respiratory muscle problems, people will develop some amount of shortness of breath, and that is a cardinal sign everyone needs to pick up to act early.
Okay, so that's a really important sign. So what would those signs be? What would I see?
So if you are asking as a patient, so the patient might experience initially problems with difficulty with sleep, probably because if you look our body as you have your muscle tone all the time, and when you're going to sleep at night, the brain is going to kind of reduce the motor activity, so the muscles relax. That includes all the muscles which keep the airway open as well, and the diaphragm, which is your main breathing muscle. But you can still breathe because the diaphragm can function pretty well. Now, in people with motor neuron disease, you can get problems with the diaphragm. That one muscle which works very well at night when you sleep might not work as well, and so the brain might prevent actually patients getting into good sleep in cycles, because when they get into good sleep, that will affect breathing. So it's a protective mechanism. So the patients can develop problems with poor sleep fragmentation. That could be an early sign.
Okay.
Otherwise, people usually develop problems with what we term as orthopnea. So this is difficulty lying flat. So classically, orthopnea is associated with heart diseases, but this is one of the other diseases where you can get orthopnea, because when you lie down, what happens is that your tummy, the effect of gravity is gone on the diaphragm, and then you're lying down, so the tummy will push diaphragm up, which is a weak diaphragm, and the lungs will struggle, and they might have problems with breathing when they're lying down.
Right.
The other problem that they will usually notice is breathlessness on exertion. So this is when they are walking and doing things, because muscles are a bit weak, so they have to exert more, and respiratory muscles might be a bit more weaker as well, and so they might develop some problems.
Okay, so they're all good things to be watching out for
They're the
and to
main
react
things.
to.
That's exactly
Absolutely.
right.
So that pretty much tells us when we should be worried, and if you see those things, get in touch. So what should I do? Should I pick up the phone and ring a respiratory specialist? Is there a referral process for us to go through?
So, as from a GP perspective, so if a patient you're looking after develops early morning headache, so early morning headaches typically usually mean carbon dioxide retention. So there are people can get headache. Headache is very common, but if you have headache in the morning which goes away within 30 minutes of people waking up, that usually will mean carbon dioxide retention, because you're waking up, body is trying to get rid of carbon dioxide, you feel better. So early morning headache is one of the important signs to pick up in people with neuromuscular disorders, in particular motor neuron disease. If they develop breathlessness on exertion, it's important to know. Poor sleep patterns, might mean that there's problems. Poor cough usually will indicate they are at risk of infections. So any of these happen, it's important to get a baseline respiratory assessment.
Right.
In South Australia, we are fortunate that we have this motor neuron disease multidisciplinary clinic, and there is good access to all the general practitioners for that with the clinic. So if you're worried, the best person to ring will be Leanne Davis, who is a motor neuron disease nurse consultant. She is approachable, and she can triage your patients to see a respiratory specialist early.
That's lovely. We will have Leanne's contact details on the tool as well, so that the GP can refer very quickly. So in managing these symptoms, if I'm the GP and my patients are coming to my primary practice, what treatments are recommended to address respiratory symptoms?
From a primary practice perspective, there are a lot of important things that GP can do as a preliminary involvement. So if you just look at the patient's journey as a whole, this is a devastating disease. Diagnosis can have big implications. So what we as a part of the group, the MDT group, multidisciplinary team, what we try to do is once the patients are diagnosed, we try and introduce the concept about different symptom management early. Okay. So not in the first visit, but probably in the second or subsequent visit, that people can develop problems with breathing, you can have developed problems with cough. So what are the things that's available? From a GP's perspective, in the community setting, the main thing to look out for will be symptoms and appropriate referrals. But GPs can also tell the patients about primary prevention, so making sure they don't get infections, because infections can be devastating, because the cough reflex is impaired, and you can cough and clear the lungs very well. So they need to have preventative vaccinations. So we recommend them have influenza vaccine annually, pneumococcal vaccine if they're not had it, good respiratory hygiene, and in the current environment, obviously, COVID vaccine when it becomes available. So preventing vaccinations is very important.
Okay.
A lot of the time problems will be with cough. So in the peripheries, they can refer the patients to chest physiotherapist. They will help with some what we call cough augmentation techniques. And then there are cough assist machines available. They're available through MNDSA as well, and we do provide them. So if they think they're at risk of infections, we generally, through our clinic, we definitely refer patients early to the cough assist, respiratory physio, for them to have a trial of the machine, because let's say you get an infection, they get an infection at some point, and they don't obviously want to end up in a hospital. If it's avoidable, then they can actually rent one of these machines and try and cough and clear up. So the machines actually push air in and pull air out, so they can effectively simulate a cough. So that will be useful. GPs can tell patients about effective postures. So as I mentioned in the beginning, the diaphragm works with aid of gravity.
Yes.
So having a bed which can be kept on incline rather than lying flat will be useful, and patients can access those kind of services through the either the NDIS or aged care. So there are electric beds where they can lift the head end of the bed a bit up. With respiratory support, the main support available is non-invasive ventilation. So this is mask ventilation to help with the breathing, and we do discuss it with the patients. The mask ventilation does improve the quality of life and also improve prognosis. So it is one of the things that is very useful in that setting, and that's done through our clinics here.
So important to respond to that need quite early.
That's exactly right. So in a GP practice, we recommend they do respiratory function test every 3 months. So essentially we look for what we call vital capacity, or FVC. If it drops less than 50%, then that's an indication that muscles are really weak.
Right.
And these are people we really keep a watch over.
Okay. So we've talked a little bit about non-invasive ventilation.
Mm-hmm.
Is there anything that you would like to say about other ventilation, or indeed withdrawing that ventilation?
Yep. So with non-invasive ventilation is in a way your complex CPAP.
Yes.
So people are very familiar with CPAP used for sleep apnea. So non-invasive ventilation for an external person, when you look at it, they look similar. So you have a mask, you got a machine. The machine doesn't look much different. So it's only how the pressures and how the circuitry and the electronics in the machine is different. So it gives a bit of different kind of support mechanism than the CPAP machine, which usually continuous positive airway pressure. So we start non-invasive ventilation reasonably early when patients develop symptoms. So the main things we look for is essentially sleep problems. So we do what we call an oximetry or sleep study at night to see whether they have what we term as hypoventilation, essentially meaning weak muscles not ventilating enough at night, resulting in rise of carbon dioxide at night, and patients not having good sleep. So that is one indication for non-invasive ventilation. If the lung functions decline quite quickly and patients are symptomatic, then we initiate non-invasive ventilation. So we try to do this as an outpatient setting. So they come in, we have the machine ventilator set up with the carer. Carers are key, and GPs are key in this kind of management, shared management in outpatient setting. So we machine set up, patients go home, and then with the newer machines they have modems in them, so we can actually remotely monitor, and we try and titrate, adjust the pressures as an outpatient setting.
Okay.
Sometimes we do have to bring patients in for 1 or 2 nights just to optimize those settings, and that also we do. Initially, they start the ventilation at night, and as the disease progresses, muscle weakness unfortunately is a relentlessly progressive disease. As the weakness progresses, they might have to use it longer and longer. So we encourage them to use it during the day if they're lying down or if they feel breathless.
Okay.
Sometimes people are worried about getting dependent on it. So, there is no real dependence on an IV. So we say it's a good mechanism for patients to offload their muscles. So give it a bit of rest. So we always encourage them to use it, and there is no problem using it more and more.
Good.
There are times when patients become what we term as ventilator dependent, meaning that they can't come off the ventilator for long enough periods. They can still use it and come off it, but not long enough periods. And that there are 2 aspects to it. Sometimes, if you look at breathing as such, if you can't breathe, then it's like you're drowning, you're in the water, and you can't swim. That's the kind of feeling. So ventilators do help with that. So we encourage them to use it for symptomatic relief, and at one point, if they want to withdraw ventilation, and that is something you can do in conjunction with palliative care services as well.
Yes.
So what we tend to do, as I mentioned, with the ventilators, we can remotely control them. So withdrawing ventilation is a process. So obviously we had to, the patient has to decide, the family has to decide, and everyone agrees that, look, there's no more, and there's no need to continue this anymore. They want to go more into the comfort palliative care pathway. We tend to wean down the ventilatory parameters so that patients develop what we term as permissive hypercapnia, so gradual rise in carbon dioxide over time, in conjunction with the other medications, predominantly morphine and midazolam we use. So it's a peaceful way of passing away, so they're not struggling. And if you ask me, permissive hypercapnia is like dying in your sleep. So it's like, gradual, so they are very comfortable in that.
Okay.
So that's the way we manage it. The only other ventilatory kind of pathway is the invasive ventilation, which you might have heard about, and there are a lot of questions on this. So in Australia in general, we don't use invasive ventilation in patients with progressive neuromuscular diseases like motor neuron disease, because it's not been shown to be useful in improving the quality of life over time. It can certainly prolong longevity in a group of patients. So if you look at US, for example, I think 10% of motor neuron disease subgroup might have invasive ventilation. In Japan, up to 38% might have, because that's a culture. So they kind of. But one of the dangers about invasive ventilation is that there is a tracheostomy. There's a hole in the trachea, and the machine is connected through that into a ventilator. And those risks that patients can develop can be locked in, because they won't have any other capacity to tell what they want to do. And in Australia, there is a particular problem with management, because it's very complicated to do that. So you have to clear the airways. You need specific nursing care. And unfortunately, there are no nursing homes here, I believe, which can provide that kind of care. So it's very intensive. So in my experience here, since we started the clinic, we had only one patient who had tracheostomy. Peter might know more, because I think he's been doing this more.
Okay.
But that's not something we usually go through. We don't go through that pathway.
So it's not a common treatment at all. And so, just bringing this section to a close, I've read a little bit about just-in-case emergency plans. Would there be any plans that you would encourage a GP to have, or a just-in-case kit or something for managing patients with motor neuron disease?
It's very difficult for the emergencies to be managed in a primary care setting, predominantly because most of the emergencies are respiratory and related to ventilator. So what we tell the patients, so we do give the patients a cheat sheet kind of thing, what to do. So we tell them during the working days, weekdays, we always prefer them to ring our NIV specialist group, so we can actually look at the machine. If they have any problems with breathing and the machine is getting clogged up and stuff, they need to come to emergency, unfortunately, because it's a very complex piece of equipment, and it's not fair to ask the GPs to do anything about that particular setting. And even if they come to emergency, they usually call us, because we need to have a good look. So things the GPs can do from an emergency practice primary practice perspective will be being proactive about infections, which I think most of the GPs already do. So what we tell the patients is that, look, if you get a respiratory infection, you need to use your cough assist. If you have already had it, you need to go into antibiotics early and make sure you are able to clear the phlegm. And clearing the airway will make them use the ventilator effectively. So most of the times patients have to come in because the phlegm is too much, you can't clear the airway, the ventilator is not functioning very well because the airway is already clogged up, and they have to come in and we have to do more. So the main thing is being proactive and treat the infections and manage secretions. That's probably the key.
So prevention, and then there is the specialisation to help if we get into trouble.
That's exactly right.
Is there anything else you would like to tell us, or to tell a primary practice GP or his staff or her staff about respiratory care, breathing and ventilation in MND patients?
So I think we have covered most of it. So this is, obviously being proactive and managing the symptoms, and then at a point we change to a combined management, including palliative care input with using, as Dr. might have already told, using clonazepam, morphine, fan over the face, breathing techniques. All those are useful for managing the symptoms of breathing, and that is definitely effectively done in primary care as well. And then obviously going into the if the patients decide that they want to they want to die at home, then obviously there's going to be GP involvement and palliative care involvement.
Absolutely.
But I think we have covered most of the other topics already. The only other thing probably is that the cough assist machines are probably, in my opinion, that are probably one of the things that have not been in focus. But I think that's a very effective intervention which can be done and initiated early.
And I know that Motor Neurone Disease South Australia have got a plethora of equipment that anyone can borrow and use. So look, thank you very much for your time this morning.
Thank you.